Good afternoon, and welcome to the National Diabetes Education Program's webinar, Motivational Interviewing, How and Why It Works for People with Diabetes. We are delighted to have so many people registered for today's session. I've been told that over 1,600 people registered and that we're breaking an NDEP record. Our presenters today will show how a well-designed motivational interviewing intervention can foster patient empowerment by making the patients themselves aware of the potential for change in behavior, resulting in improved diabetes treatment and care. We believe this webinar will allow all of us to learn more about how several motivational interviewing diabetes education programs were performed in rural and other settings, as well as the methods that were used for client counseling. By the end of the webinar, it is our hope that you will see how motivational interviewing can be integrated into daily clinical work with diabetic patients to bring about clinically relevant effects that benefit our patients. Our first speaker is Dr. Jan Kavokian. Jan is an Associate Professor of Health Outcomes Research and Policy at Auburn University's Harrison School of Pharmacy. She will provide a brief overview of motivational interviewing concepts and skills with a focus on provider-patient encounters related to diabetes self-management behaviors. She will also share with us her perspectives from her 15 years of experience in training providers from across the spectrum of health professions and lay leaders. Her presentation will end with highlights from diabetes intervention projects that include a study of pharmacists trained in motivational interviewing for use with diabetes patients coming for medication refills, and a diabetes education program implemented in a southern rural minority community. Jan?
Well, I am delighted to be presenting today with my distinguished colleagues, and welcome to all of you today. We have been asked to each spend about 12 minutes giving you our perspectives on training and applications, and I have also been asked to overview some of the MI concepts. So I'll be spending about 4 minutes on the overview, and I regret that it's going to be so brief because I have looked at a lot of the questions that you all have posted, and many of you are looking for information about the concepts and the rationale for MI. And unfortunately, in our brief webinar today, we won't have time to get too deep with that. But I did put together a reference list for you. I had my PhD student Gladys gather some of the latest literature, some systematic reviews, probably from about the last 10 years, and some landmark pieces, as well as a list of books. And the book that we use most frequently is Motivational Interviewing in Healthcare. It's the one that I use as the textbook in the MI elective courses that I teach at the PharmD and graduate levels, and also one that I recommend when I do a training. But I would also like to point out that on that list is a book that's coming out this year from my co-presenter, Mark Steinberg. It's coming out, I think he said, in August. And so I want to draw your attention to that book because we're very excited about that particular one as well. I guess just to kind of dive right into this overview that I hope to give, motivational interviewing is about behavior change, and I know I'm preaching to the choir. You're here because you were looking for how to intervene to help patients decide to make changes, and in diabetes it is so complex and it's a very individual thing. And MI has emerged in chronic disease management, especially in diabetes, because of that complexity and individuality. And it is a patient-centered communication skill set and way of being. You've probably heard the patient-centered term outside of MI. It is an evidence-based concept in and of itself, and it's about tailoring to the patient preferences, literacy level, cultural norms, and just, their individual motivators and barriers. And I'm sure if you think about your own behavior changes, we're all working on something, aren't we? And the things that motivate me are going to be very different from the things that motivate you, even if we're working on the same target behavior. So MI is this communication skill set and way of being that brings us directly to this particular person while taking our own preconceived notions out of the picture. It has its origins in the addictions and counseling fields. Miller and Rolnick are the originators. And, there are several of us in behavior sciences and disease management across healthcare that saw that success in those difficult target behaviors and thought, wow, we should take a look at this for health behavior change in relation to disease management or health promotion. And so the evidence base for MI is expanding rapidly. As a behavior scientist, I've been in MI for about 17 years, but in the last decade in particular, we have just seen it explode worldwide. And at last count, to my knowledge, it's been translated into over 17 different languages. And if you look at the literature, not just in our resource that we've posted, but elsewhere, you'll find such a diversity of populations, target behaviors, conditions, providers, settings, countries, etc. And in fact, we're seeing an important adoption of MI by professional associations at the national level for dissemination to their healthcare provider members. For example, the American Association of Diabetes Educators, or AADE, has been immersed in MI for quite some time. I've been doing some MI things for them over time. The American Pharmacists Association, the Case Management Society of America, which is predominantly training nurse case managers, and several others that I could list. It's showing up in practice guidelines for entities like the American Diabetes Association and in health professions education accreditation standards. So the evidence base is growing rapidly, and I wish I had more time to tell you about the evidence base. I think the one premise that I hope that you'll take away from this is captured in this quote out of the MI in Healthcare book that I have here at the top of the slide. We tend to believe what we hear ourselves say. So MI is about interviewing the patient in a way that the patient ends up giving the input and making the argument for the change. And it's about interviewing the patient in a way that it is eliciting this notion of internal motivation. And in fact, we've been talking about internal motivation and looking at it for about a half of a century. It is certainly required for lasting change, and it is an important premise in motivational interviewing because everybody has something internal that is important to them that can be tied to that particular target behavior. But unfortunately, all the strategies that prevail in healthcare are external push or pull, and that can do more harm than good, as noted in these couple of sub-bullets on the slide. So patients are going to, by push or pull, they're going to either feel violated and resist further, or they're going to make that temporary change, and they're excited about that temporary change while they're with you. But then when they go home and they get away from that external push or pull, they're going to fail. Probability is they're going to fail and relapse and then feel even less confident about making or sustaining a change because of that failure. So MI also includes this way of being, or it's known as the spirit of MI, and this is a really critical part. And in fact, it's a part that can be very challenging to healthcare providers trying to use MI. So if you think about the origins of MI in psychology and counseling, the persons that are working in that realm are highly trained in communication skills. They have a background in psychology and psychosocial aspects of behavior change for patients. And they often have a 50-minute psychotherapy session, and that's not always the case with healthcare providers. Now, if you look at the things on this slide, a lot of these things are things that people in those professions are trained to do, but healthcare providers often don't get that training in their health professions education. So for most of us, and I include myself in that us, it requires a mindful act of will to decide you're going to set your judgments and your biases and your need for control in this interaction aside, so that we can be collaborative and patient-centered and listen carefully to where the patient wants to go in this encounter. And so we do that with these MI communication principles. The 5 things that you see listed on this slide have been part of the foundation of MI since the beginning. And I put expressing empathy at the very top because I personally feel that it's one of the most important aspects of MI. Empathy in and of itself is evidence-based. I was immersed in empathy before MI, and it's actually what drew me to MI initially. It is about listening to what feeling that patient is expressing and then reflecting that back to the patient in its simplest form, because we all want to be understood, and feeling understood helps us feel less alone in this encounter and in this effort at change. Now, expressing empathy is not saying, I'm sorry you feel that way, and it's certainly not saying, I understand how you feel, because you probably really don't understand, and that is problematic in and of itself. Expressing empathy is saying something like, you sound really discouraged, Mr. Smith, or Ms. Jones, it's clear that this seems very unfair to you. And then down at the bottom of that list, supporting self-efficacy. In all my years of training providers across professions, that's the one that I see is typically the easiest to embrace. It's about supporting what they are doing, even if they're thinking about making a change. So it might be something like, that's great that you're thinking about quitting smoking, for example. And then there's also what we refer to as the micro skills in our training model. And our training model pulls in this notion of we're doing this in the context of comprehensive disease management, the clinical aspects as well as the behavior change aspects. So we think it's very important to pull into this the context of talking about this in terms of what they understand about the diagnosis of diabetes and the risks that they are susceptible to if it doesn't get under control. And so we pull that out into the conversation early on. We have the patient answer that question, or we support their autonomy by asking permission to fill in the information or advice that they need, after we've elicited from them first. Hallmarks of MI include some of the other things on this slide, like asking open-ended questions, engaging change talk, which Miller and Rolnick themselves have emphasized how important change talk is in recent time. That is really the pivotal piece for the internal motivation. And so it's about asking questions like, what do you see as the benefits for this particular target change? Or what would be the reasons for you to engage more activity into your routine to bring your blood sugar down? Those would be the kind of things that you might ask for that. And then, of course, setting incremental goals to build self-efficacy with the hope that building small successes can help in confidence for bigger change. So that brings me to this notion of training, because if you think about it, healthcare providers who are being trained in MI are actually facing a behavior change in terms of their practice behaviors. So our philosophy is that we use MI to train MI. We focus on incremental changes. This is very important in training healthcare providers who, again, don't have those backgrounds that we talked about previously. Sometimes I get invited to come do a 2-hour training, and I don't even want to call that a training. I would call it an overview that at best we could do some awareness raising with. The evidence base says that we really need this to be at least a 2-day workshop. I've done it in less than that. I don't like to, but I know that a lot of care settings have a hard time setting everybody aside for 2 days at a time. But really the evidence base says it needs to be at least 2 days with more than one role play, with MI expert feedback, and some form of follow-up training or practice opportunities or coaching, as you'll hear Mark talk about in just a moment. And some things that we've learned as well, kind of coming from the academic side, from adult learning theory and strategies that work and don't work in helping adults, especially intelligent adults, learn skills, is the critical aspects of cognitive development first, and then going into the skills application process. I worry about settings where persons are going into a brief training and then they're being thrown into role play, and this can be particularly problematic because they're not ready and it can destroy their self-efficacy for that. So I am just going to briefly tell you about this particular project that I had the great honor of consulting with for the American Pharmacists Association. And this was about medication adherence in non-adherent diabetes patients who were recruited into this project. And my involvement was training the pharmacists in MI and helping to develop these structured communication prompt pieces. These were some paper-based pieces that you could actually see an example of if you can acquire the article, which is cited there on the slide. And so essentially these patients came in for their refills every month for 6 months, and they talked to the pharmacist for about 5 minutes using these little prompts. And at the end of that time frame, medication adherence had increased and satisfaction had increased. And then I'm not going to linger on this project because in the interest of respect for my colleagues, I'm going to move on. I just want to highlight there are things in this project that are similar to the things that the Kentucky group will be telling you about, and it boils down to the engagement of community health workers or lay helpers. That's a critical part of cultural tailoring and developing relationships when you're going into a particular community that might have, say, minority or rural characteristics. So that concludes my portion. I thank you so much for your attention, and I encourage you to contact me if you want to know anything more about the things that I've covered or potential training opportunities in the future. Thank you.
Thank you, Jan. You've talked about how motivational interviewing can be a useful intervention strategy that can empower participants. Do you believe that MI outperforms traditional advice given in the treatment of behavior problems and diabetes?
I absolutely do, and the evidence base certainly supports that. A little bit of MI, and actually MI, even portions of it, can be even time-saving compared to traditional advice giving as well. A little bit of MI is better than a lot of advice giving, which can be violating to patients.
Thank you. Our next speaker is Dr. Mark Steinberg. Mark is a motivational interviewing trainer with the Group for Quality Care. He will discuss the client-centered counseling techniques he used during motivational interviewing to stimulate behavior change. He will wrap up his presentation by offering information on lessons learned as a result of those interventions. Mark?
Good morning to everybody. I'm still in morning. Some of you may be in afternoon now, but I am glad to be able to speak with you today, and I'm looking forward to sharing some information with you. But more importantly, I want to ask you a question. Have you ever been sitting in a consultation room working with somebody, and suddenly this invisible 3-foot wide panel of concrete descends from the wall? You're on one side, and the client or patient you're working with is on the other one. Well, I suspect that may have happened at some point in time, that loss of engagement in a conversation. In the 1990s, physical exams and visits with physicians were largely related to meeting clinical practice goals, or guidelines rather, and these proliferated in the 90s. And I got really I've always been involved in quality care, and I had this difficulty. There were these people who wouldn't do what I would tell them to do. And I wondered, why is that? And basically what I found was that it was not a problem that they were having, it was me. I had very little training in behavior change, and I was more than halfway through my practice when these clinical practice guidelines appeared, and I wanted to do something about it. I felt very much as though I couldn't move forward with patients and help them achieve better health. MI is what ended up happening. Over a period of years, I discussed with my wife how frustrating it was not being able to reach some people, and I finally ended up serendipitously getting this invitation to a meeting to learn motivational interviewing about 15 years ago, and it just lit up my life. I basically found out that, yes, there are ways to learn behavior change, and it gave me a feeling that there was some hope for working with people who had challenges, who were struggling, or completely ignoring self-care in diabetes. Most of my practice, and towards the last years of my practice, I did exclusively diabetes care. The good news is that MI is learnable, but it's easy to understand but difficult to learn, and a lot of that is because it's skills-based. Imagine learning how to play the piano. You can't go and listen to your piano teacher play and then be able to play yourself. It takes time, and it takes repeated exposure to the aspects of playing a piano. The important thing about MI is it's not dependent on your educational level. MI is a style of practice. It's a way of conducting conversations or sharing conversations with people that use many skills that we already have as well as some that we have to learn. When we use MI, listening is critical, and for me, listening is the most difficult task in the world. If I tell you about, or if you tell me about a fishing trip you went on in Montana where I live, and you tell me what you did last weekend fishing, it immediately evokes or involves my thinking of experiences that I've had fishing. And it's very easy for me to disconnect from what you're saying and to think about my experiences. So the most critical skill is listening and listening carefully, because we have to differentiate among different types of utterances or statements that people make. Change talk, sustained talk, signs of ambivalence. Change talk basically is anything that sounds like you're willing or interested in change. Sustained talk is, I'm okay where I am. We don't look at people as resistant in MI. We look at them as people who are happy with where they are, even though it may be an unhealthy place to be. And we look also for signs of ambivalence. It can become very difficult, and this is where the training comes in distinguishing these different types of utterances. For example, if I come to your office today for diabetes education, had type 1 diabetes for over 40 years, I could come in and say something to you like, gosh, I really had a hard time getting off work for this appointment. And when I drove up in your parking lot, I wanted to wait about 5 or 10 minutes. I'm not even sure I want to be here. I've had a lot of trouble with this diabetes, and it's difficult. Is that change talk or sustained talk? The answer, obviously, is I showed up and I'm telling you this. So there is some change talk here. If I were in a sustained talk mode, I might have backed out and gone somewhere else at the time of our appointment. The other thing that's really important about listening in MI is the heart of MI is not questions. In fact, in healthcare, most people ask questions more than reflections. Reflections are simply listening to the client, the patient, and then taking what they say and repeating it back to them along with a guess about what it meant. And that, in effect, stimulates more conversation and is really the key for evoking the patient's own ideas and plans. So, for example, I go in and see you and I say, I really don't like checking my blood glucose at night. And you say, why don't you like doing that? I can answer the question, well, it hurts. But on the other hand, you say, you're having problems with that, Mark. You don't really feel that it's useful for you. Well, no, I know it's useful. And again, I go on and extend and provide more information. The important thing about MI is that reflective listening, using reflections rather than questions, is really the key. It's the heart of MI, and it's very hard to get going without that skill, and that's the most difficult skill in MI. Patients always offer us feedback. The invisible 3-foot concrete wall that descends between two people and sort of ends engagement or disengages one another is an example of that. Also, people nodding their heads or talking with you, that gives you feedback. People, when they argue with you, that's a very dangerous place to go because we avoid discord at all costs in MI. But it's listening to the patient to find out what you need to do next. MI isn't mastered in a 2-day workshop, as Jan pointed out. It takes both practice and coaching. The coaching part of it is a bit like a piano teacher. If I wanted to learn how to play the piano, I would play for somebody in the course of learning it. I'd go to their house or to their office and play what I was supposed to practice during the week. When this came to me in motivational interviewing, this coaching part where I was being coached, I was very fortunate. I was working with a psychologist and two psychologists, in fact. We were working on research projects in motivational interviewing. It helped a lot to work with them because I got a great deal of coaching from them. That was in my early MI years. And we started also doing trainings, which helped as well. But the coaching's really important. If you want to, for example, if I am learning how to play an electronic keyboard and show up at my teacher's for a lesson, I really don't want to play in front of you today because I'm not really sure I can do it. But I'm not going to turn on the keyboard. You can just watch my fingers. You can't hear me. And it's hard to learn in that mode. So one of the best ways, really, of learning MI is to do a training and then to be sure that you get follow-up. Recording interviews and receiving feedback from them is a really good way to learn. When I started doing that, I found it enormously difficult, and I felt very vulnerable. And in fact, in a number of conversations, I really was got a lot of critical input and observations that I needed to make some change if I wanted to call my style of practice motivational interviewing. It was a bit disappointing, but it was presented in a way that just to change that, you could do this, this, and this. There are a lot of trainers across the world. There's a group called the Motivational Interviewing Network of Trainers, Minties, that are part of motivationalinterviewing.org, and they have trainer profiles there. And you can also get together with a local group. I've been meeting with the group of those two psychologists and now a psychiatrist who's joined us on the first Friday of each month for well over a decade. That's another way that we end up discussing MI. Over the years, I've been very fortunate to spend a lot of time in motivational interviewing, and I've spent the past 2 years working with Bill Miller, who developed motivational interviewing, and I've written a book in motivational interviewing in diabetes care, which will be coming out in the summer. But there are a lot of other good motivational interviewing resources. You can't learn MI from reading, that's for sure, the same way you can't learn tennis from reading or watching it on television. But Motivational Interviewing, the third edition, Helping People Change, is really the tome for MI and a very worthwhile book if you're interested in this. We're going to move forward and hear other people's experiences with MI, but I really appreciate having the opportunity to speak with you today.
Thank you, Mark. You pointed out how motivational interviewing should be performed and how to use the methods of counseling to maximize our efforts. In motivational interviewing, is there a specific time frame for follow-up to avoid the risk of counseling failure?
There is research on learning motivational interviewing. In today's world, what I try to do in trainings, which is based on that research, is to not do so much a 2-day training all in one dose, but to do 1 day intensively and then get back together in a month and go forward and to work on where people have been in the past month. Recording conversations is worthwhile. It's difficult to do because people are busy and because of the vulnerability people feel doing it. But generally speaking, in the VA study, they did a recorded conversation once a month. Most of the people that I've worked with do them every 4 to 8 weeks. And they involve basically somebody listening, me listening to the tape, and then providing them with written feedback and asking them to make an appointment for a conversation to discuss it. It's a very positive activity. It's not negative or critical.
Thank you. Our final presentation will include remarks from a team of presenters. They include Dr. Pamela Yankee Love, who is Professor and Associate Dean of Student Services at the Kent School of Social Work, University of Louisville. Dr. Joseph D'Ambrosio, Assistant Professor, University of Louisville School of Medicine, and Luana Hester, who is a diabetes peer mentor with the Kentuckian Regional Planning and Development Agency. They will provide us with an overview of how motivational interviewing was used as part of a community health worker diabetes peer mentoring program in Kentucky. Their presentation will provide a description of their program, how motivational interviewing was used to shape the work of the peer mentors, along with examples from one peer mentor. Can we have the team from Kentucky?
Hi there. Thank you so much, Carol. Our peer mentoring program is part of a larger grant initiative. Now, the CDC provided funding to KIPTA. KIPTA is an area agency on aging organization, and the University of Louisville Kent School of Social Work to, in part, develop a coalition. And our coalition's goal is to create a community for individuals living with diabetes and organizations to support one another and advocate for healthier communities. Our peer mentoring program is one of the activities of our rural coalition. Our peer mentors are typically individuals who have experiential knowledge of a stressor, such as diabetes, and have similar characteristics to the target population. The concept of peer mentoring comes out of a community health worker model. Our peer mentors explore feelings and social support, problem solving, goal setting, and self-efficacy with their mentees. Our program is based on two theories, social cognitive theory and social norms theory. Social cognitive theory suggests that a person needs to know what to do, how to do, knows consequences of the actions before engaging, and has confidence in their ability to be able to execute the desired behavior. Social norm theory focuses on correcting misperceptions of perceived norms. And motivational interviewing is the practice perspective that's layered over those two theories. Our mentees are actually supported by our mentors, of course, who are supported by community organizers and a clinical consultant who is also supported by the coalition. And the initial objective is for the mentees to reach certain goals, and the ultimate objective is for the mentees to actually become part of a community of carers, specifically in our community and the coalition. And the program really has more of an egalitarian relationship between the mentor and the mentee, something a little bit different than what you would get with a health professional and a patient. So our peer mentoring program begins with a program intake to identify priorities of the mentee. Then the mentee and the mentor come together and they share their story. They share their journey of what it's like taking care of their diabetes. Then there are 9 subsequent sessions, alternating face-to-face and phone contact. And sessions 2, 4, 6, and 8 talk about priorities that have been identified by the mentee in regards to their health management, their self-management of their diabetes. And then we do alternating phone contact. There's also, the last month, there's 2 phone check-ins in the final month. And we also aim to have some field trips if possible. And the field trips would be, again, to the community, to the coalition, to support groups, to exercise programs with the mentor. The unique features of our peer mentoring program is that our peer mentors are persons thriving with diabetes who live in the counties of our mentees. And as I said, social support is one of the initial sessions because we're assessing for social support within the home, outside of the home. We attempt to connect the mentees to like-minded individuals in the community. We use the existing coalition, as well as we have a public-private partnership in the sense that we have materials from pharmacies and pharmaceutical companies, ABA, as well as NDEP. Right now I'm going to turn over to my colleague, Dr. Joe D'Ambrosio, who's going to talk to you about the training.
Thank you. We had a dilemma in trying to decide how to train our peer mentors because most trainings, as you heard from Jan and Mark, are done over a 2 or 3 day period. And it really does take a long time to learn the process and really make it part of your life, we decided to put this project together and this training together in a short period of time because our peer mentors, although they're being paid the paltry sum of $10 an hour, we like to look at them as volunteers also. So I'm going to be talking about a lot of the items that Jan and Mark talked about, so maybe this will help reinforce some of the motivational interviewing process for you. The basic motivational training that we did was a 3-hour training. We started with a pre-test, and in that pre-test, we asked our mentors if they would answer 3 simple questions. And these are questions or statements that a mentee would typically make. So if our mentors heard their mentee say, "I know you mean well, but I'm never going to get better," how would they respond? And they wrote down that answer. Our second question was, "I don't have time or support to do what you want me to do. I want to get better, but I don't know how to do it." Our mentors wrote down the answer to that. And then our third question or statement from our mentee would be, "I failed before and I will probably fail again." So at the end of the training, we asked those questions to our mentors again, and we really did see a change in the way they answered them, from the way they started before they heard about motivational interviewing to when they ended. We then proceeded to introduce MI with the 3 main tenets of the process: style, skill, and building motivation. We tried to make it less a lecture and more a conversation, modeling MI ourselves. Style was introduced by showing the Stop It video, which is an excerpt from the Bob Newhart series and is available on YouTube. If you haven't seen it, please watch it, as it shows what many of us have always wanted to do with a client, and that's yell, "Stop it." It's the opposite of MI, but it shows what not to do. We then reinforced MI style, explaining that it's not a technique, but rather a way of being with a mentee, learning how to dance with their mentee, and introducing many of the tenets of MI, which are already embedded in what these people do every day. We then focused on showing mentors that MI is a different way of being with someone we are trying to help. In the MI world, we call it the MI shift, that allows a mentor to let go of the need to change the mentee, but rather support them on their journey to help. This relieves the mentor of the responsibility of having the mentee change, and instead allows them to let go and enjoy the process of change, watching their mentee grow at their own pace. We ended this session with another YouTube video of a very bad MI session, where the therapist started to metaphorically twist their client's arm to get them to stop smoking. It was the opposite of MI and allowed us to hone in on a process that was shown that does not motivate change. If you're interested, that video is on YouTube, and it's called "How Not to Do MI, a Conversation with Sal About Managing His Asthma." Get Real is an acronym that is used in MI that is a template of the style that MI requires. Jan and Mark already mentioned respect, empathy, active collaboration, and listening. Isn't this the way we really need to treat each other on a daily basis? They're pretty self-explanatory, but when you're trying to help someone, the helper forgets these simple instructions about being with another human being and instead tries to force change. So we gave explanations in detail. Respect is having a deep admiration. A mentor has to believe in the mentee has worth of their own and in their own decisions. Believe in the trustworthiness of their mentee. Believe that they will help themselves and that they have what it takes to change. Empathy, the ability to share someone else's feelings, not pity, and no need to have a similar experience. Active collaboration involves partnership. It's not something done by an expert to a passive recipient. It's not something done for a person, rather it's something done with a person. And then listening is being present, undivided attention, curiosity, delight in being okay with silence and using encouragers such as, I see, Okay, go on. Really? No way. What else? Tell me more. We focused on listening for change talk, but there's not sufficient time in this first session to anchor this in. In our conversation with the mentors, we tried to emulate the MI principles by listening for change talk in the mentors. We really tried to emphasize stop fixing. This is hard because those who are helpers want to help clients get better, and there's a natural response to fix clients. So we talked quite a bit about taming the writing reflex. And then finally, we went into some skill building with the ears, explore with open-ended questions, ask for elaboration, how, what ways, ask for examples. We went over the negative effects of closed-ended questions, affirming our mentees, honoring their strengths and attributes. Mark mentioned reflection, which I agree is one of the main parts of MI that we all have to continually practice, simple or complex. We gave them some short ways to respond to a reflection by saying to a mentee, so you feel, or it sounds like you, or you're wondering if, or it seems that you, or you're feeling so-and-so. And then summarizing, pulling all of the elements that a mentee has offered and collecting them in a bouquet that the mentor was able to hand back to the mentee. And we ended our training. By this time, our mentors looked at us a bit confused because so much was covered in a short 3-hour session. We briefly touched on recognizing resistance as a signal to change strategies, and the resistance could be arguing, ignoring, interrupting, withdrawing, negativity, or denial. We briefly touched on developing discrepancy. We emphasized asking for permission to give advice and normalizing mentees' actions when it was appropriate. But overall, this was a bit much on the first round. And then finally, the main message to the mentors is that shift happens. Don't worry about getting MI right. Rather focus on joining with their mentee and be themselves. The skill of MI can be practiced over and over again. And as you do it over and over again, you do get better.
We also did some ongoing mentor support in which we had weekly meetings with the mentors, and the mentors would come together and they would give case presentations. They would talk about what was going on with their mentee. We would also provide support via the telephone, and if there was any additional need outside of those weekly meetings and telephone support, we would do case-by-case analysis.
Well, let's hear a little bit from Luana, who's one of our mentors. Luana, how did you shift from wanting to direct change to allowing change to happen?
It's hard not to want to force people to change. But from my training in motivational interviewing, I learned that if I force someone to change, it won't last long term. The change that motivational interviewing is trying to accomplish is long term, and it comes with the mentee finding something inside that motivates them. It is not about what I think the mentee wants. I like to ask my mentees what they like and what they want, what makes them happy, and then accept them as they are.
How did you begin to ask permission before giving advice?
One of the main things I've learned from motivational interviewing is that it's about building trust with the mentee. Part of building a trusting relationship with anyone is to always ask permission before you give advice. I have found that when the opportunity arises for me to share, I say, is it okay if I tell you what works for me? Or is it okay for me to tell you what worked for my other mentee? This way it is not me forcing my opinion or ideas on mentees without their permission. I remember when I was working with my mentee who was always glued to her couch. When I brought up a subject like exercise, she'd turn away, look at a lamp beside her couch. This is a clear sign for me to back up and try another approach. I then said that it might be a good idea for us to get up and walk around a bit. I asked her, how if we get up and walk up and down your hallway one time? By the time I returned a week later, she told me she was walking around the hallway 15 times a day. That made both of us happy.
That's good. What do you feel you did to encourage intrinsic motivation to arise within the mentees?
It was really more about me listening to and getting to know the mentee than me doing anything to get them to do something good for themselves. One thing that I learned in my motivational interviewing training was to listen for any words that could get the mentee to shift to a better place for them. I worked with a mentee who was of Asian descent and eats bowls of rice that are not good for his diabetes. I learned how important the rice was to him because of his culture, and I also learned the importance of his family. His daughter is his intrinsic motivation. He was willing to modify his diet because he knows if it makes him healthier. Motivational interviewing is really about me listening with a much deeper standpoint. One thing I want to add to this, that gentleman, blood glucose went down 30 points.
It's amazing.
Yes.
As a mentor, what's the best lesson you learned from MI?
I think the most important lesson I've learned is to first develop a trusting relationship with my mentee. Slow down and don't go fast. Just relax with the mentee. Be who they want to be while a trusting and a deep relationship is made. I love getting to know people, and this program gives me a chance to get to know great people while also doing something good for them and me. I couldn't ask mentee to do things that I wasn't doing. Example, glucose testing, watching what and the amounts of food that I ate.
Well, thank you, Luana. We appreciate you sharing, and thank you for being a mentor. I know your mentees love you.
Thank you, George. I love them, too.
Yeah. I just wanted to conclude by saying that we have some great results from our peer mentoring program. Our mentees report high satisfaction with the program. They report increased perception of support. They also have increased self-efficacy on all of the diabetes-related self-management tasks. They increase in their self-reported blood glucose testing, and there's trends in the increase in their fruit and vegetable consumption. And as Luana has told us in many of our trainings and case conferences, it's hard because we all want to be fixers. And we have these great mentors that are extraordinary in the way that they manage their diabetes, and they want to impart those experiences with their mentees because they want to reduce the mentee's suffering. But Joe often reminds us in our trainings that we have to kind of wait for the cheese, basically be patient. So I'm going to go on and conclude there. Thank you.
And thank you. You underscored the importance of the motivational interviewing setting and program design for mentors. Are the duration of sessions and the number of participants important in mentor training?
Well, the less number that you have, the lower number that you have is better. But what we found is not so much the training, it was the follow-up. So we gave them an opportunity to call us when they had questions. We met with them. We did problem deconstruction. And it was this ongoing connection that we have with the mentors that really helped them learn MI.
All right, I thank you for that. We're at this time ready to accept questions through the chat box. If you have questions, would you please forward them now?
So, hi Carol, it's Alexis. We have lots of questions coming in already. One group of questions is around training. There are questions about whether people can get online training for MI, what are some cost-effective ways to get training, and I think one of the speakers covered this, what are some ways that people can sort of support each other in a community of practice.
All right, do we want some of our speakers to respond to that?
This is Jan, and I will just say that there are lots of opportunities for training out there. I know Mark was telling you about the network, and I know his group, and I do training, and there are other organizations out there that do it. It is something that works best in person. Now, sometimes some of the cognitive development aspects of training can be done, online or, via other media. But when it comes time for the actual skills development training portion, it's very important to be doing that in the presence of, and at least facilitated by an MI expert who can be, giving feedback for that.
Luana was saying that MI training online would have not worked for her.
No.
It was that meeting with her in person and that constant feedback where she knew she could make a phone call to ask a question when she was stuck. That's what really helped her.
It definitely did.
I think while the emphasis is on training, and that is important, getting together and doing training, really the key to learning is coaching. Getting together with a group playing piano doesn't always help your piano playing or my piano playing. And so when you think of training, it's really important to think of it as a ball of activities that needs to be on this side with a group, and then at other times in a smaller, so that you get one-to-one feedback on how you're doing. Because that really makes the difference in becoming more satisfied with using MI. The neat thing about MI is that it doesn't just change the people we work with, it changes us and it makes our work a lot easier, and there's actually evidence that basically shows that people don't look at an appointment list and say, oh no, look who's coming in at 3 o'clock today. That guy's so hard to deal with. I mean, those were the only people I saw the last 3 years of my practice, and I look forward to seeing each of them.
I think one thing I will add to that about training, I think that the group model has evolved because it's efficient, and it is just kind of a way that it seems to be done in healthcare settings because it's an efficient way, to get a number of people done. So an important strategy, and this works on adult learning theory as well, has to do with doing some team building and rapport building at the beginning, because you're trying to develop a culture of MI if you're coming into a healthcare setting and trying to train a group. So you're trying to create this culture of MI. So there's some team building that happens in the beginning, and then engaging everybody in the feedback process contributes to the learning of everybody, even in the, some of the role plays. If you've done a good job of setting the comfort zone and the team building in the early part of the training, then once we get to the role play process in small groups where everybody's giving each other feedback, they can learn from the process of hearing others receive feedback, the process of critically evaluating to give feedback, but also so that that person who's receiving the feedback can learn from that as well. And that is a model that has worked fairly well, at least for the initial part, as Mark said.
Let's move on. Mark, is the healthcare book available in an audio format? I think you had talked about a healthcare book, and someone was asking if it is available in an audio format.
The MI in Healthcare book is a Rolnick, Miller, and Butler book, and I'm not sure if it's available in audio, but I know Mark's book is coming out this year, and it's MI and Diabetes Care, and we'll just defer to him to tell whether that will be available in audio.
Thank you. Has MI efficacy been tested amongst communities of color?
Definitely. The evidence base has seen it applied in a lot of minority populations, again, across conditions and particular target behaviors, but there are a couple of great studies out there in African American communities, Hispanic communities, Asian communities. Like I said, it's been translated into over 17 languages at last count that I saw.
Ken Resnick, University of Michigan, has done incredible work in inner city settings with weight loss, and all the counseling took place in churches for the most part. And people providing the motivational interviewing, the people who were sort of developing the motivational interviewing skills, were members of the church, some of whom did not have high school educations. They hadn't completed high school, and they did a wonderful job. I think that study was reported in 2002. It's a very interesting one, and he continues in that vein of work, Ken Resnick, University of Michigan.
And you're saying that it can be applied in a group setting?
There's a very good book, Motivational Interviewing in Groups. It's a little bit different in groups than with individuals, because when we're with individuals, we're evoking their ideas, a specific individual's ideas. And when we're doing it in groups, we have to sort of control who talks, in a sense. Not control, but influence who talks, and make sure that everybody has a voice in the conversation. So it's a little bit different, and it's a little bit more difficult to do in my experience.
How do we deal with a patient who does not want to change his A1C levels as recommended by a provider, or doesn't work to change his A1C levels or any of his labs?
That is a complicated question that will be hard to answer in a moment or two. I will just say that's a resistant person, and it's very important to just roll with the resistance, empathize with it, explore it. Let the patient talk about that, and it's hard to really answer that in 2 minutes because that is a lengthy conversation. But I would say that an initial response is to, empathize and roll with it. Don't get into an argument with that patient. Try to engage them in change talk, open-ended ways of, what they know about the benefits or how important it might be, what their long-range vision is for their health, and trying to develop some discrepancy between the attitude about the A1C and the long-range future hopes for their health.
In terms of dealing with people who are in a situation of status quo and don't want to change, I think that's an important question because we think of MI as a way of helping people resolve ambivalence about change. But in people who seem disinterested in change, we use MI to create ambivalence. So a lot of the conversation hinges around speculative questions and things of that nature and helping them to find ambivalence.
Many of the primary care offices are very busy places. How do we integrate motivational interviewing into their setting?
Well, I think, we've presented to you today some comprehensive models of MI, all the concepts and some of the perspectives of everything you'd need to know. And not every encounter is going to include everything we've highlighted today. And in fact, if you only have 2 or 3 minutes with a patient, being MI consistent in that 2 or 3 minutes means you might engage in a few of the strategies because you're not going to have a comprehensive conversation in that brief amount of time. But I think one thing that Luana said that I think is a key is, it's about building trust. Building the relationship is the foundational objective here. And in primary care, hoping to see that patient continually over time and developing that relationship. And so hopefully there will be time at some point to have a more lengthy conversation if needed, or even to bring in other collaborative providers to help in the comprehensive behavior change piece of that. But I think that even just a little bit of MI, active listening, being collaborative, using open-ended questions, even thought-provoking questions. I think Mark just said something about asking these thought-provoking questions that can be very, very discrepancy developing to get people to just kind of think about making that change. Being empathic, not engaging the patient in further resistance.
All right. Can you offer any advice on how to engage clients when working with health insurance companies, making outreach calls to try to get them to work with the nurse on their chronic conditions?
Well, I actually had, this is Jan, I had a lot of experience with that in the past. I had collaborated in the past with Case Management Society of America, and the majority of their participants were nurse case managers doing telephonic case management, and it works the same way. I mean, even though it's on the phone, and unfortunately over the phone you lose a lot of the nonverbal aspects of the communication, like being able to have the patient see you, nod, and engage in direct eye contact. So it's very important to think about voice tone and those kinds of nonverbals that are so important on the phone. But the process that's done face-to-face is still what you would, apply in over the phone. I think one thing that I encountered in trainings with nurse case managers doing telephonic is that they often have a checklist. There's a protocol that they have to follow, and there's a checklist. And so they are struggling with how to be MI adherent, and yet they've got this checklist that they have to complete. So my recommendation with that has always been to tell the patient up front, I have this checklist that I'm going to have to complete as part of the protocol for this conversation. But before I get to that, I'd really like to just have a little conversation with you to see, how things are going with you. And so you engage in a few minutes of that, open-ended questions and MI, and chances are you're going to answer through that rapport building some of the questions on the checklist anyway. And so then you steer the conversation back around to the things that you have to complete on that checklist, and then you can engage it at that point.
Moving on, and we have a question. How long would it take to be a real expert in motivational interviewing?
You don't have to be a real expert in it. You just have to keep doing it. Over time, it takes probably, there are studies that have shown that in 6 months with follow-up, people go from 0.2 reflections per question to about 0.8 or 1 reflection per question. And that's a big change. Generally speaking, learning how to speak reflectively, where you're doing basically one question and 2 or 3 reflections, takes some time, but it's very achievable for those who are interested in doing it.
This is Joe. When I went through training, I went through hours of videos that I had to send in, and I was rated. But I agree with what Mark is saying. I think I learned motivational interviewing more by doing it, and then having peers that can challenge me and help me learn this new way of letting go and just journeying with my clients rather than forcing them into doing what I want them to do.
Another participant is asking, how do you talk to a patient who's scared of the side effects of their medication?
Basically ask them what they know about the medication initially, find out what their knowledge is, and then use that as a jumping point to offering information. And there are ways in MI to offer information, asking their permission. Would it be okay if I gave you some ideas? You have a good idea of what's going on with that medication. Would it be okay if I provided you with some other information?
And also spending a lot of time on reflecting their fears. So what they're feeling is real, and not being afraid to stay with them in that fear that they have.
All right, we have another question. Is it difficult to get men trainers to train folks in healthcare because they charge up to $250 an hour? This is too expensive for most clinics. Can you help with resources for getting training that is not as expensive?
There are a lot of us in Mint who work with organizations that are having that difficulty. And so that is definitely done regularly. That's something that you really have to reach out to specific trainers and ask where they are with that. So you have to really get the list from motivationalinterviewing.org, and you can almost always find somebody who will do that.
Next question. Are there situations in which you do not want to use MI?
Well, this is Jan again. I think it's important to remember that MI is about volitional control over behavior change. And yet, we still can use it in a situation like with your teenagers. You know, they don't have a choice about keeping the curfew, right? Hopefully they don't have a choice. But we still can use it in that context. Or an employer could use it with employees, even though that employee has to come to work and fulfill those responsibilities to get paid. But it really is geared for situations where one has volitional control over making that target behavior change. One thing that I will say is it is important to remember that it works optimally. There's certainly aspects of MI, being collaborative, the spirit of MI, and so on, that you would use with persons who are not cognitively capable, persons with, say, dementia or Alzheimer's, or persons with mental illness or learning disabilities who can't cognitively process. Then your approach with MI would be a little bit, considerably different. But you still could exhibit the spirit of MI, and oftentimes you might be talking to the caregiver in the case of dementia and Alzheimer's, and you would use MI with that caregiver, but you would be hopefully trying to also engage the patient to the degree that that's feasible.
Thank you. Would you please talk about MI in relation to the stages of change or the trans-theoretical model of change? What are the connections to the two and the differences?
They both focus on behavior change, but MI is not the trans-theoretical model of change. We look at people either who are interested in making change and are struggling with it because they're either ambivalent or have other things going on, or there are people who really are satisfied with status quo. That used to be called resistance, and it's viewed as a state that people are in because that's where they want to be. And what we do with that group is basically try to do some of the stuff that did come from Walnick's work and Miller's work in creating ambivalence. And so it's a little bit different than stages of change sort of counseling, where we view people at, one of several levels of making change.
This is Jan. Having done extensive work in the transtheoretical model before immersing in MI, I think it's a great method for assessing where one is in terms of motivational readiness. I have kind of moved away from that, even though that was the focus of my dissertation research. I only really use that so much in research now. If I need to have a measure for how adherent someone is, I might use a staging algorithm. But I think when you're talking to a patient and you're being patient-centered, I caution against spending your thought process on pegging someone into one of 5 stages and putting a label on that. I think MI is, as somebody said, it's more of a dance and patient-centered. You're following where the patient is going, and the transtheoretical model grew up separately from MI, although they both arose at similar times and they're very complementary. But MI, I think, is more of the strategy for what to do next, whereas I see the transtheoretical model being very relevant if you're trying to gauge, where someone is.
So at this time, we are all out of time for questions. We know there's still lots of questions in the queue, so we're taking these down, and we will send them out to the presenters and get responses back to people who hosted questions. You'll also get a resource list in the follow-up email to this webinar. So that resource list will probably answer a lot of the questions that you have. So this time I'm going to turn it back over to Carol to wrap up. And thank you so much for joining us. And thank you to the presenters for answering all of those questions.
Thank you, Alexis. On behalf of the National Diabetes Education Program, I'd like to thank all of the presenters for sharing their profound knowledge about motivational interviewing. And for our participants, we hope that the information provided can be used by each of you in some way for the benefit of patients. As Alexis indicated, unfortunately, we are unable to get to every question. However, again, I will repeat that NDEP will compile all questions and share them among the co-presenters.